And we're live. Hello. Thanks for joining us, everyone. We are back tonight to talk about endometriosis. It's Endometriosis Awareness Month, and we had so much to say about this topic that we couldn't quite fit it all into one. So last week we talked about what it is and how to know if you have it, and tonight we're going to focus on treatments for it. And for that, we have a special guest with us, Dr. Oja Cairns. Would you please introduce Dr. Kimble?
Yes, this is Dr. Thomas Kimble. Kimble, He is an associate dean at Eastern Virginia Medical School and assistant professor at the Department of OBGYN. And so we're so happy to have him here today to speak with us about endometriosis, and specifically what we're going to be talking about are treatment options. Last week, we spent a good while talking about the pathophysiology of endometriosis, what endometriosis is, and tonight we're going to focus on how a woman can be treated.
Yeah.
So go ahead.
I was going to say thank you, Dr. Oja Cairns and Hannah. I'm really glad to be involved, and I'm really excited. This is Endometriosis Awareness Month, and so I'm glad that it's a disease that more and more people are aware of. It's been in the background for far too long, and now it's in the forefront, and people are aware of this disorder.
I mentioned last week that I have endometriosis, and it was such a long time before I figured out what was going on, and I just attributed it to painful periods, and it just took me forever. And in the time between last week and this, we had some great resources that were shared with us that I'm going to drop into the chat right now. But this first one is about barriers to care for women with endometriosis. So if you're interested, listeners, please go check that out. And then I'm going to drop another one here that is about endometriosis fact sheet. And on it, it has a listing for number of hours on average missed in work for women with endometriosis. And I found it so incredibly validating.
Yeah, last week, and to your point, Hannah, what you were just making about how long it took you to be diagnosed. Some of this information, I think maybe you're putting in the chat, the Society for Women's Health Research quotes that many women have a delay of a time from first feeling symptoms to actual diagnosis of 7 to 12 years. And so imagine that entire time battling a disease that no one sees, but you feel, and not having that validation of a diagnosis. How sad that is. And so I really hope tonight we're able to reach many women who may be dealing with the disorder, with the disease, and give them some information that helps move them forward.
Dr. Kimble, you said that it's only kind of recently coming into like the awareness. Can you tell us a little bit about that? Why now?
Yeah, I will tell you, and just to reiterate some of the information you shared already about that 7 to 12 years before people get a diagnosis. I mean, that's really unfortunate for a disease that's so common. I will tell you, 22% of women have seen 5 or more medical providers, so doctors or nurse practitioners or physician assistants, before they get a diagnosis. 5 or more. 55% of women with endometriosis have seen more than 3 doctors before they get the diagnosis. That's the majority. Yeah. So there has been a delay, and I will tell you, a lot of it goes back to some of the historical ways that we used to diagnose endometriosis in the medical community. We created some of our own barriers to it, unfortunately. I remember in being a medical student, and Dr. Oja Cairns can probably say this. She probably learned the same thing when we were in medical school. We were taught that endometriosis is a surgical disease. And if you did not have a surgery where endometriosis was seen, you can't call it endometriosis.
Yeah.
We know that's not true. The American College of Obstetrics and Gynecology and the American Society of Reproductive Medicine both have very clear statements that endometriosis is a medical disease. As providers, we should be diagnosing medically and managing it medically if possible. The other thing that we were taught in medical school is that endometriosis is a cyclic disease, meaning that it's a disease of pain that comes and goes with your menstrual cycle. The pain that people experience with their menstrual cycle, we call that dysmenorrhea, is the medical term for that. That is true. That is an indicator of endometriosis that a lot of people experience. But there are a lot of women that have a pain between their periods, so intermenstrual pain, or just regular pelvic pain. And when I was a medical student, I was taught that's not endometriosis if it's not cyclic. So we kind of created some of our own barriers. The other thing is we know that a large percentage of women will present only with pain with sexual intercourse. Something a lot of people have, and that's difficult for some people to express. And so there have been studies that show that a lot of women have difficulty articulating some of the issues that they've experienced with endometriosis, which, you know, probably also goes back to the medical community, because nobody should feel uncomfortable explaining things to their physician.
Yeah,
or their
exactly.
Yeah.
And I to just speak further about, you know, how we as a society have almost normalized the pain that women experience around periods. You know, that's one of the barriers there. And also just, you know, Dr. Kimble, like you were saying, the lack of knowledge of just the disease process itself. And so that lack of knowledge is not only with patients, but just as you were explaining, with the physicians and or practitioners understanding the disease itself. So
Right. So current estimates are that about 10% of women suffer from endometriosis. I feel extremely conservative estimate. I think it's still very much underdiagnosed, and I think the percentage is probably much higher than 10%.
It seems like it's one of those things amongst many things that I've experienced where it's only when you admit that you had it or you have been diagnosed that you find out how prevalent it is. I mean, it seems like miscarriages in a way that you experience it and you feel so alone if that's the case. And then you find out, oh, so many people have experienced this. We've got somebody in the chat who said that they've also experienced it. So since I was first diagnosed, it seems like there's been some movement forward on treatments. Can you guys talk a little bit about that?
Yeah, sure. There actually have been some pretty significant advances recently. So there are two just general approaches to treatment for endometriosis: medical management and surgical management, as we had discussed before. Medical management, we usually think first line to take medications that can help decrease the inflammation associated with endometriosis. So endometriosis is anytime the lining of the cavity of the uterus, called endometrium, is anywhere in the body other than in that cavity where it's supposed to be. And when it's in other areas, it releases inflammatory markers which create inflammation. And inflammation is what causes the pain. So medications that decrease inflammation are typically thought of as first line. And that would be things like your non-steroidal pain medicines, simply ibuprofen, which is good, or naproxen is another example. And there's a whole host of members of the aspirin family, and COX-2 inhibitors is another type of medication that we sometimes use that actually work pretty well. One thing for people with cyclic pain, we always recommend that they start it before they're even having symptoms. So a lot of my patients will come to me and they'll say, I took ibuprofen when I was having pain and it didn't help. And so when I tell them to take it a few days in advance, when you can kind of tell it's coming, that's when it's ideal. And take it around the clock. And I usually recommend through the first 2 or 3 days of your period, and you'll notice that makes a huge difference. The other class of medications we consider first line would be your hormones. It's like birth control hormones. So things like the contraceptive implant, contraceptive hormonal Iuds, which stands for intrauterine device, the little T-shaped devices that we place in the cavity of the uterus. Those tend to work very well for endometriosis. There are other tiers, including your intermediate types of birth control, like injectable forms of birth control. Right now in the United States, Depo-Provera is the only injectable form. And then tier 3 is what we call your temporary forms of birth control. And that's things like birth control pills and the birth control patch. And in tier 2, there's 2 contraceptive vaginal rings. There's the once a month ring called NuvaRing, and there's a once a year ring called Innovera. So those are typically first line. It helps a lot of people. It doesn't help a lot of people. And so it's really important to let your provider know how you're doing. And this isn't something that should take years. It's not going to be like a light switch. There's no treatment that's like a light switch where we can just turn it off. But it also shouldn't take months and months and years and years. So if you're not feeling better after trying these first line things, let us know. And sometimes you have to make sure we hear you also. Then there's another fairly new second line form of medication. And we know that the hormone estrogen tends to drive those implants of the endometrium that are in other parts of the body, and their growth and how they express these inflammation. And we know that the inflammation then causes further levels of estrogen to go up, so that's why endometriosis is a mean disease. It's self-propagating. It makes its own self worse. And so when we can tune down the estrogen, people tend to do a lot better. That decreases the inflammation. For years, we had the big guns that didn't tune down estrogen. They pretty much shut off estrogen. And an example of that would be something called leuprolide acetate, or the brand name, we call it Lupron. And there are long-acting forms of Lupron that we call Depo-Lupron. And that's usually good anywhere from 1 month up to 3 months. But that's a big gun. That doesn't just tune down the estrogen levels. It shuts it off, and it puts people in what we sometimes refer to as an artificial menopause. And so instead of gradually, naturally going through a menopausal transition, it is kind of an overnight thing. And, people, it works well for endometriosis and some of its associated symptoms, but it does come with side effects like hot flashes and mood swings and problem sleeping. And medically, it can also cause the bones to become a little weaker over time. So it's nice to have something in the middle between the anti-inflammatory medicines and the birth control and that big gun, the Lupron. So it's a new class of medications called elagolix. I'm really excited to have been a member of the development team for it. I do a lot of research in disorders like endometriosis and uterine fibroids. And so I was one of the investigators in the clinical trials when we were bringing this for development so we could eventually get it out to the market for people. And one thing that is exciting about elagolix is that you can take it by mouth. And that's something we had strived for years. People want oftentimes to control their care, and they don't want to have to come to see us in order to get their medications every month or every 3 months. Sometimes it's just more convenient to do things yourself and be able to take your own medication by mouth and not to have your doctor have to give it to you. So that was a big gain. The problem with that class of medicines is for a long time, we couldn't get it absorbed through the stomach. But we figured out a way to alter the molecule a little bit. So now you can take it by mouth and it's absorbed and it works really well. And it brings estrogen levels down. Some of the side effects are still hot flashes, and mood swings can happen too, but to a much, much lesser extent. There are a couple of different doses of this medication. The lower dose, about 24% of women have hot flashes. At the higher dose, about 48% have hot flashes. The big gun that I talked to you about, the leuprolide acetate, almost 96% of women on that one experience hot flashes.
Yeah, I was gonna say everyone.
Yeah, everyone. So we hear it all the time. So it's nice now that we have a whole new option. And when more options became available, all of a sudden there was an interest in this disease. And then you started seeing commercials about it. And that was great because women who had this, who like many of you felt isolated and alone and didn't realize how prevalent it was. You saw, oh, wow, remember the commercial, the lady couldn't figure out what to say to her doctor about it. Then she had a little voice in her head speaking to her. And, campaigns like that and awareness and having an endometriosis awareness month, now people know about it. And that's great because we're right at the intersection where there are more treatment options available.
That's so great to hear. It makes me wonder, though, if you are roughly around the age of kind of maybe thinking about conceiving, I know that conceiving can be also a treatment for it because you're ultimately trying to stop your period, but also a side effect of endometriosis is it can be difficult to conceive. So right now, it seems like the over-the-counter pain medications, am I understanding correctly that would be the route to go if you're thinking of conception if you're of age and think you might not want to turn it off and have hot flashes just yet?
So what some people will do is we will try to help them by temporarily writing down their endometriosis. And then when they're ready to take a break, when they want to start or expand their families, we can work with them together to come up with a treatment regimen that will still help them feel good and not experience the symptoms to such a bad degree, but also let them expand their families. So there are some hormones that we can give that help with endometriosis. It helps quiet the estrogen levels. It helps calm down the endometriosis implants, but don't prevent you from getting pregnant.
That's great.
Yeah.
We've got a question in the chat. Is this the same as spongy uterus?
Okay, maybe adenomyosis.
Yeah, all right.
Okay, yeah.
Break it down in layman's terms. I'm here with spongy uterus.
So remember we said the endometriosis is any time that lining of the uterus is anywhere other in the body other than in the cavity where it should be. So sometimes that lining actually grows into the muscle of the uterus. So the uterus is a big muscle. It's typically a little bit smaller than the size of my fist. And when that endometrium grows into the muscle, it gets larger, it gets spongy, like you said, you're right on the ball. And that disease is called adenomyosis, as Dr. Karen said. Something that I'm glad that you guys recognize this, because unfortunately, a lot of insurance companies don't recognize that adenomyosis is a type of endometriosis.
Yeah.
So it's a variant of it. And so the treatments for endometriosis should also be covered for adenomyosis.
Mm-hmm.
Dr. Ojo-Karens, what did we miss?
Well, we didn't talk a lot about the surgical options, and the surgical options are good options. They're options that are necessary in many instances. Options to ablate or burn, to excise or cut endometriosis through laparoscopy or robotics or even an open procedure. Operations to remove the uterus itself with a hysterectomy or remove the uterus with the ovaries. So these are other options, but they should not be the first options that anyone considers. Medical management should be the first line of management for anyone with endometriosis. And unfortunately, I think a lot of women do end up having surgical management a little bit too early, just because they weren't optimized as well as they should have been medically.
Wow. I'm sure that we haven't even skimmed the surface, and that's kind of the idea, is to just touch on it a bit, bring some information. I've learned so much and I have experienced this. Thank you so much, Dr. Kimble, for that information. And what we encourage is, if this has raised more questions in you, either send them to us if you can, or meet with your physician or health care provider to get these questions that you have answered specifically for your scenario. We are coming back next week to talk about general and chronic pelvic pain, and then the week after, pain with sex, and then the week after, libido loss. So stay with us. We're back next Wednesday night. Thanks again so much, Dr. Kimble, for joining us and for that welcome.
Thank you.
Thanks for having me.
Thank you, Dr. Ojo-Karen.